بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم.
وأيوب إذ نادى ربه أني مسني الضر وأنت أرحم الراحمين فاستجبنا له فكشفنا ما به من ضر وآتيناه أهله ومثلهم معهم رحمة من عندنا وذكرى للعابدين وإسماعيل وإدريس وذا الكفل كل من الصابرين وأدخلناهم في رحمتنا إنهم من الصالحين وذا النون إذ ذهب مغاضبا فظن أن لن نقدر عليه فنادى في الظلمات أن لا إله إلا أنت سبحانك إني كنت من الظالمين فاستجبنا له ونجيناه من الغم وكذلك ننجي المؤمنين وزكريا إذ نادى ربه رب لا تذرني فردا وأنت خير الوارثين فاستجبنا له ووهبنا له يحيى وأصلحنا له زوجه إنهم كانوا يسارعون في الخيرات ويدعوننا رغبا ورهبا وكانوا لنا خاشعين.
Real expert in the field of nerve surgeries. So let me introduce our speakers for today. We will start with the talk of Dr. Pervez Hashmi, who has been heading this section of orthopedic for the last 5-6 years and is now a leading surgeon for nerve surgeries at Aga Khan University. He will introduce you the anatomy and pathophysiology of peripheral nerve injuries, followed by Dr. Kamran Ahmed, who is also alumnus of Aga Khan University, and he is now heading the section of orthopedic at Indus Hospital, Karachi. Then we have an expert in the field of nerve transfer, Brigadier Khalid Masood from HULS, Hand and Upper Extremity Surgery, CMH, Lahore. Welcome everybody. This is an honor for me to have all of you and the participant. This was indeed a very distressing and very disturbing period we are about to over the pandemic of coronavirus. And thanks to my team and all the speakers who has given us an opportunity to connect you through the web link. Of course, this cannot replace the face-to-face interaction required for socialization and educational activity, but at least we started doing something, and alhamdulillah, we have now conducted almost 18-19 webinars. And I will now request Dr. Pervez Hashmi to take over and start his presentation on anatomy and pathophysiology of peripheral nerve injuries. Dr. Hashmi, please share your screen.
Thank you, Dr. Haroon, for your kind words. You see, I thought that I will actually talk about a basic anatomy of a peripheral nerve. pathophysiology of a nerve injury, and then following that, Dr. Kamran and Dr. Khalid Masood, they will take over talk on that component. You see, I have arranged my talk in a way that I will first talk about the structure of a peripheral nerve, how a spinal nerve is formed, arrangement of the nerve fibers in a peripheral nerve structure, then what are the different classification for nerve injuries, pathophysiology of a nerve injury, especially for regulating degeneration and regeneration, then the various techniques of a nerve repair and nerve blocking, and finally I will talk about assessment and the results about peripheral nerve injury. Now, if you look at the cross section of a spinal cord, how a peripheral nerve is formed, we can see that in a spinal cord, there are two rootlets which are emerging from the spinal cord. Ventral rootlets, they are from the inferior motor horn cells, and the dorsal rootlets. In dorsal rootlets, they are emerging from the facialis gracilis and the cuneatus. These ventral rootlets, they are the first order neuron which emerge from the inferior motor horn cells. But these dorsal rootlets, they are not actually first order neuron. Basically, these are the extension of the neurons from the dorsal root ganglia. So these are the second order neurons which enter into the facialis gracilis and the cuneatus, and that is the pure sensory rootlets. Dorsal root ganglion is from here the peripheral nerve fibers which come into a spinal nerve. These two rootlets, they join and form a spinal nerve. Now the spinal nerve is a very short structure depending upon the level of a spinal nerve. In a cervical region, it would be very small. In a lumbar region, it would be a large because the spinal cord ends at the level of L1. Now this short spinal nerve, it receives the two contributions from the synthetic ganglion in form of a white and gray remicommunicans. White remicommunicans is a preganglionic and remicommunicans is a postganglionic nerve fibers, which give the synthetic contribution to the peripheral nerve, which control our vascularity and the synthetic tones of vessels. So this is how a spinal nerve is formed. Then the spinal nerve, it divides into a ventral ramus and the dorsal ramus. And we know that the ventral ramus, it supplies the anterior half of body, while the dorsal ramus, it supplies the posterior half. Like in a cervical and in a brachial plexus, we talk about the ventral ramus, which are the main actually peripheral nerves which are being. Now, when we look at the nerve as a whole, it's a cross section. The whole nerve is surrounded by a very thick membrane, which we call epineurium. And this thick membrane or epineurium is not only the fibrous tissue membrane, but it has a blood vessels. It protects the nerves and various fascics from the stretch, from compression, and it is a source of blood supply and nutrition to the various nerve fibers. Now, looking into the further detail of each nerve fiber, we can see that nerve fiber is an extension of a plasma membrane of a neuron, and it extends in a longitudinal fashion, which we call as an axis cylinder, and this axis cylinder is actually an extension of the cell body. It is surrounded by a Schwann cell membrane, which we call the myelin sheath and the Schwann cell. And outside this Schwann cell membrane is a thin laminal layer, which we call endoneurium. Now, endoneurium, these various small nerve fibers, they form the various bundles, and the various bundles, then they are aggregate to form a fascicle, and this fascicle is surrounded by a membrane, which we fibrous tissue membrane, which we call a perineurium. So this is an epineurium, perineurium, and the endoneurium. This concept is very, very important, that these longitudinal blood vessels, which are running into the epineurium, we can see that this is just written words that how that axon or axis cylinder extends to form peripheral nerve fiber or an axon. And this axon is actually, it contains conductive material which is secreted within the cell body, and they are transferred to this extension. And it contains various proteins, microtubules, microfilaments, to the end organs, because these nerve fibers, when they terminate at the level of its target organ, they actually further divide into a small finger-like projection and make connections. And these connections we can see, these connections, it can be a sensory connection or a motor connection, and depending upon the sensory and motor connection, these synaptic nodules or synaptic knobs, they contain the various neurotransmitters. And we know that that neurotransmitter, in case of a motor connection, it is basically acetylcholine, while in a sensory, depending upon where it is making connection, the various neurotransmitters they are present. So this is the structure of a peripheral nerve cell, its extension in an axon or axis cylinder. This concept is very, very important to understand. Surrounded by Schwann cell sheath, and outside this is an endoneurium. Because when we classify the nerve injury, we try to correlate this microscopic structure to a structure and the impact of an injury. Now, we know that looking at its blood supply, there are two major sources of the blood vessels, which especially on the surface of an epineurium. These are the two major arterial systems, and inside this epineurium, these longitudinal blood vessels, they are running. And each nerve has a one median large blood vessels, which is contributed segmentally as it passes from its from an proximal to the distal region. It contains various segmental augmentation of that blood vessel. But most of the vessels, one large vessel running over the surface. Similarly, that major arterial system is actually anastomosing with an inner system. This is the outer blood vessel we can see, and similarly it is anastomosing with the inner blood vessels, which are from epineurium to the perineurial blood vessel they are actually running. Then along with each endoneurial tube, there is a small capillary arterial system, not arterial, this is a capillary system, which we say that their cell bodies, they are tightly adherent, and they actually form a sort of a barrier which allow only certain nutrients to pass through that, and it provides the nutrition to the blood vessels. There are to those nerve fibers. Now, coming to its nerve injury, most of you are familiar with the two gentlemen who described this nerve injuries, Seddon and Sunderland's classification. Now, the Seddon's classification, everyone is familiar that it has a three major components: neuropraxia, axonotomesis, and the neurotomesis. Neuropraxia means cessation of conduction of a nerve pulses along the nerve. So there is no structural damage, only there may be disruption of a myelin sheath. Myelin sheath, it may be disrupted, but axis cylinder or axonal extension, that is intact, endoneurial tube is intact, and the whole nerve is intact. Temporarily, it stops conduction, and if conduction is stopped, both sensory and motor component would not be perceived by the patients. And here you will see that there is no structural damage. This is a grade 1 neuropraxia. In Sunderland classification, neuropraxia and the type 1 is the same one. Then second grade in the Seddon classification, it is an axonotomesis. Axonotomesis means axon is disrupted. There is only a cell body which actually sends a peripheral extension in form an axis cylinder or axon, that is disrupted, while its endoneurium as well as its Schwann cells, they are intact. Perineurium and epineurium, everything is intact. So we presume that as in a type 2 of Sunderland's classification, we know that axonotomesis was further divided from type 2, 3, and 4 by Sunderland. So its type 2 only endoneurial tube is intact, and there is an expectant recovery with it. While its type 3 of a Sunderland classification, here not only axon, endoneurial tube is also damaged, while the perineurium and epineurium is intact, so there would be some recovery. And in type 4, we know that there's a loss of continuity of axon, endoneurium, and the perineurium, while the epineurium is intact. Here, we presume that there's a partial injury, maybe a laceration, half a laceration, some of the bundles they are lost. And in type 5, And the neurotomesis, we know when the nerve has been completely severed, so there is no connection between the proximal and the distal segment. Now, we know that without a nerve transection, if after injury, short of transection, the function of nerve actually it fails in the following order. And this is very, very important to understand the concept of a nerve regeneration and nerve recovery, how assessment occurs. First of all, the motor function actually goes away, then proprioception goes away, then touch and temperature, lastly the pain and the sympathetic function they go away. So that is the order in which there is a loss of function, and similarly recovery occurs sequentially in the reverse order. In the same order, when we will talk about the assessment and this actually Medical Research Council assessment guide, how that S1, S1 plus and S2, S2 plus, S3, S4 actually occurs in a reverse fashion. The pain and the sympathetic function, they were the last one to go and they're the first one to come back. That's very, very important to understand this concept. Then a nerve injury, we know it is a problem. Most of people, we actually encounter this. And when a nerve is injured, although various mechanisms they exist, it can be compression, it can be laceration, gunshot, traction, avulsion. I will not go into the details of those actually things. We are all familiar with the various mechanism of injury. But what happens at the time of, at the zone of injury, where this changes occurs in the distal segment in form of a Wallerian degeneration. Similarly, there are changes to the proximal segment, axonal degeneration occurs, and then how the Schwann cells they respond in form of a regeneration to the distal segment, and how the cell body responds in the regeneration to forming the growth bone. Now, immediately after the nerve injury, and diagrammatically, I will show you here, first thing which occurs in the proximal half of the body, cell body, chromatolysis occurs. That the body becomes eosinophilic, Nissal's granules, they disperse, cell, its nucleus becomes an eccentric in position, and all these changes in an effort for preparation of a formation of a growth cone. So these are the changes which occur, and sometimes these changes occur into only up to a couple of proximal node of Ranvier's, but it may occur to the cell body, and some of the cell bodies, they definitely die, depending upon the level of injury and the severity of injury. Then the Wallerian degeneration occur in the distal segment. We can actually look at this diagram carefully and spend a couple of minutes. This is the peripheral axon. Here is the cell body. Once this axon is cut, and this is a distal organ making its connection to the muscle or to a skin, to its target organ, immediately after injury, what are the changes? Changes occur in the cell body in form of a disappearance of Nissl granules, its nucleus becomes eccentric, and whole it becomes eosinophilic. That in the distal part, we see that the endoneedle tube, it shrinks. Schwann cells, they actually gather together and they form a longitudinal bands, and we know those are called the Wenger bands, which we can see here. Then, as this cell bodies over a period of next 10 to 12 days, these microtubules and microfilaments, they start synthesizing, they follow in its laminal membrane, and in form of a growth cone. And growth cones, it has a microphylopodia, which will go distally try to find these actually degenerating part of distal portion of endoneedle tube, and they penetrate this growth or a column of Wenger's granules and try to find its distal organ. And how nerve then regeneration. And everyone knows that this regeneration usually starts after 10 to 14 days, and regeneration rate is a pretty slow. It is in roughly, we say it's a 1 millimeter per day. And in common terms to patient, we say it's a hardly 1 to 1.5 inch per day, depending upon the age of patient and the level of injury. Now, this growth cones, it responds to the various neurotropic factors, neuroid promoting factors, laminin and fibronectin, and there are certain actually metabolic and other factors also which can enhance the growth of this growth cone. Now, clinically, we see that if we look at the Seddon classification and Sunderland classification, what are the pathological findings? how Wallerian degeneration, motor, sensory, autonomic, and the muscle atrophy. So these parameters, how they are seen. Anatomically, we know that in a neuropraxia or type 1 of a Sunderland classification, only there is some discontinuity of a myelin sheath. There is no Wallerian degeneration will occur. Motor and sensory recovery, although its deficit occurs, but most of the time this recovery would be almost complete. Xanotomesis 2, here we see that excess cylinder, that cell body which sends a peripheral extension axon, that is a damage, and there would be a complete recovery in terms of the motor and sensory component. Then we see in form of a grade 3 neurotomesis. Here there would be a recovery, but it may not be a complete recovery. It is really progressive with the passage of time. And in a neurotomesis of a type 4, or we call xanotomesis type 4 injury, usually there would be some sort of a recovery. And here we do see, as the nerve is partially damaged, there would be some neuroma and continuity also. And in type 5, there would be no recovery unless you repair it, or the nerve ends they have been, after being severed, they are lying within a proximity of 1.5 centimeters. So in those situations, the proximal end, it can regenerating bone, it can find the distal end and the nerve can regenerate. So the same thing I will actually repeat here. In grade 1, usually it few weeks to few months it takes. The two elements which I have added here is a penal sign. You see, this is the most important question which is asked from the students, in which cases tinal sign would be absent. It would be absent. What is a tinal sign? The tinal sign is a sign of a regeneration and degeneration of actually nerve. When there is a structural damage to the neuron, like excess cylinder, nerve will start regenerating. In those cases, sign of regeneration, you tap along the nerve from a distal to proximal, you will see a conducting sensation. They go to the its end organs. So that tinal sign would be absent when there is no structural damage, or the nerve has been damaged completely and there is no connection between the two ends. So mechanism, we can see that this is a very important slide, the way I was talking, that how actually nerve function goes away. I will just go to the previous slide. The first is the motor, then proprioception, touch, temperature, pain, and the sympathetic function, they come back. You see, in this pattern, the nerve function is lost, and in the same pattern, nerve function comes back. We know for motor recovery, when there is no muscle contraction, we say that's a zero problem. In M1, there is some perceptible contraction, but not able to move the joint only in the proximal muscle. In M2, there is some perceptible contraction in the proximal and the distal muscle, still they are not able to move the joint. M3 is the one where you see that there is some return of a function and there is ability to move the joint, eliminating the gravity. And type 4 is there is some power against the resistance, but not 100%. And in type 5, M5, we say that there is a full recovery of all this. When we talk about the sensory recovery, as I told you, then there is no recovery in the sensation. We say it is S0. S1, the deep pain sensation. The pain sensation, they go last, but they come back first. S1 is a deep pain sensation come. S1 plus superficial pain sensation come. S2, when apart from pain sensation, touch sensations they come. And S2 plus is when there is over response. S3, pain, touch, and temperature sensation, they come back, and there is a disappearance of over response. And S3 plus person is able to localize his pain, touch, and from where the pain is coming, but the 2-point discrimination is not 100%. And S4, hardly we see when the 2-point discrimination, at least statics come back, but the moving 2-point discrimination, it may not actually come back. So if you look at the cross section of a nerve, here the bundles, they are arranged in a various fashion, and as we trace the cross section of nerve from a proximal to the distal area, there is a lot of actually crossing between those various fascicles. The nerve fibers, they cross from one fascicle to another fascicle, and this pattern, it has been observed by both gentleman Sunderland. If you look at his atlas, there's a big, huge atlas which actually shows that how the nerve fibers, they are crossing from one fascicle to the other fascicle. And there's a good example that you can see in the arm. The ulnar nerve actually giving sensory branches to the triceps muscle. Many people who do actually ulnar nerve decompression, they have noticed it is giving various sensory branches to the triceps. And there are various communication between the ulnar and median nerve in the arm and the forearm also, which have been noted. So whenever you are thinking a nerve repair, the first and the most important thing is that you should be familiar with its cross-sectional and topographical anatomy, and you need to realign those bundles. Thick bundle to thick bundle, thin bundle to thin bundles. And the most important thing is that the one vessel or the median nerve which is running within the cross-section, you try to realign that nerve to nerve end. Now, nerves, they can be approximated. The best principle is you try to do a primary repair, end-to-end repair. But how you can do that whenever you actually nerve is severed, usually ends they detect that. So you make a longitudinal incision proximally and distally. With a dissection of a 1 centimeter of a segment, you get 1 millimeter length. So if you dissect 10 centimeter proximally and almost 5 centimeter distally, you can get actually a centimeter extra length. So you need to actually do a tension repair. That's the most important. But if repair is end-to-end is not possible, ultimately we have a various techniques of bridging the gap with the tubulation technique, with synthetic material, with the nerve graft, which are the most popular things which we use. I'm not going to the detail that this slide shows various neurotrophic factors which helps in the regeneration of the nerve. But primary nerve repair is done when optimum conditions they are available. And optimum conditions they are when there is wound is clean, good vascular supply, there is no crushing element, adequate soft tissue cover, and underlying bone is stable. It means if there was an associated fracture, it has been stabilized. If the above conditions not prevail, then the repair it can be delayed 2 to 3 weeks, which is called delayed primary repair. And the type of repair, most commonly, at least I do an epineal repair. I have tried actually fascicular repair under the microscope in early days of my training and early days of practice, but there is no additional advantage of doing that. If you can realign the bundles and repair it with 8 to 10 no suture, depending upon the circumference of a nerve, the results would be good. If your repair is a tension free and anatomically those fascicles they have been realigned. There are various other techniques to match the bundles for a sensory and the motor bundle, various training techniques available like for cholinesterase for the motor, carbonic anhydrase for the sensory, but it is a little time consuming and people they have actually tried it to get an optimum result. Although the electrical stimulation is possible, but it is only possible when there is early and fresh injury within 2 or 3 days of original injury. You know that autografts they can be used, especially the sural nerve is the main source, but medial cutaneous nerve for arm and forearm it can also be used. Superficial radial nerve and the lateral cutaneous nerve of the thigh, they are the actually sources, but ultimately there is a cost for sacrificing sensation to that particular region. Various types of graft, we know the cable graft, and the whole nerve trunk you have taken, that's a cable graft. And not actually cable graft, we use that when the nerve is taken and the various vesicles they are joined together and you try to form a cable just like you open an electrical wire and you see those longitudinal bundles within that cable. In the trunk, you take the whole actually nerve and try to actually bridge that defect between those ends. Vascularized nerve graft, there two are the most popular. One is the ulnar nerve vascularized graft in case of a complete brachial plexus injury, and other one radial nerve which I have started to use over the last few years. I actually use radial nerve dissected all the way based on its profunda hemorrhage brachii artery because there is one artery which actually runs along with it. Here it is because our aim is only median and ulnar nerve to renervate, so the radial nerve it can be used the vascularized nerve graft also. So we know that allografts they have been tried, but initially there was a lot of rejection in those. But nowadays, when there are better techniques of preservation, they are available. These grafts they need actually a banking, storing capabilities, and a proper treatment. They can also be used. They are handy, and you do not have to sacrifice the nerve of a person, which does require an additional incision also. Now, postoperatively, once the nerve has been repaired or it has been grafted, it needs an immobilization. This is very, very important concept. You cannot leave the arm, upper and lower limb without any splint and a cast, and the immobilization has to be minimum of 4 to 6 weeks to provide a mechanical strength to the epineurium. Once the mechanical strength is enough after 6 weeks, you can remove the splint and start early motion in those situations. Splinting is very, very important. And following that, many people, they actually suggest rehab exercises, hydrotherapy, and then electrical stimulations, especially cardiac nerve stimulation, to keep the muscle alive. Although these stimulations, they do not actually help in the nerve regeneration, this is for the muscle to keep their muscle fiber active and alive. Now, the various techniques of a nerve repair, we know that the best technique, which I find, is an epidural, and most of the people, they agree. But the fascicular repair, it can also be done. Fascicles, they can be arranged with a tenosuture, and then over the fascicle, you can do an epidural repair. Uh, Accurate approximate is very, very important, especially in injuries, knife, glass cut injuries, where you encounter sometimes a partial injuries of nerve. So you do a proper dissection, expose, mobilize the proximal and distal end, approximate the ends, and then you can do a repair. And the repair has to be a tension-free repair. As I was telling you that the proximal distal end, this should be dissected and get an extra length and try to approximate with a nerve approximator, and then you do a repair, and repair it has to be with a fine suture. 8 to 10 or nylon suture is a pretty good material because it gives direction at the site of the repair. As I was telling you, the primary repair is immediately after injury, delayed primary repair within 3 weeks, and secondary repair after 4 to 6 weeks. These are regarding timing of repairs. Many times people, they are actually hesitant regarding the repair. They say, okay, we have seen with the naked eye, nerve is intact, most likely it is intact. There is and people say possibly it would be intact. But the best thing would be to explore the nerve and repair it in case of a doubt. Dr. Kamran will talk about nerve injuries regarding the fracture and the gunshot injury, so I will not actually touch that. But this thing should be avoided. You see, to control the bleeding, when you clamp, you actually crush the ends of nerves also. Many, because this is a blind thing, you are trying to actually hold the blood vessel, but at the same time, you are actually crushing the nerve ends also. Now, outcome, it depends upon the many factors. Associated injuries, age and compliance of patient, gap at the nerve site, what kind of nerve, what type of nerve is there, and at what time you have repaired, the level of nerve injury, and then, of course, it also depends upon the technique and the experience of the surgeon, how he has actually repaired it. A couple of examples of a radial nerve. Whenever I do a radial nerve repair from elbow to axillary, I always do an internal splinting. An internal splinting concept is that we do a transfer of a pronator teres to extensor carpi radialis brevis tendon, so that this extension comes and he doesn't need actually a wrist brace or cockroach splint to keep the wrist in extension. And that is the result you can see here. There is another example of actually a nerve grafting, that here. This is a lady who had actually an injection in the deltoid, but incidentally that injection went into the radial nerve. And I have a series of 6 cases in which that injection went into the nerve, and then I had to excise a segment of the nerve and put a graft inside. And this is the graft you can see. This is the cable graft that you take a sural nerve, cut into equal pieces. Another important about the graft is you always take an extra length of graft, 15 to 20% extra length of graft, to give an adequate and tension-free repair. Because once you measure exact graft, when you put into the defects of shrink. So ideal thing is to always, if it is a 6 centimeter, to make it a 7 centimeter. Keep it relatively longer so that the repair is a tension-free. And that's the result. It was really amazing result. I could see that she had a full grade 5 power in that case. There's another case in which a nerve was repaired with an internal splinting, and you can see there is some lag of a dorsiflexion on the wrist, but a pretty good result. Another case where radial nerve actually grafting was done, and these are the results. The difficulty occurs in cases when you actually come across with an avulsion injury, especially in case of a reimplantation. This is a very old case when I started my practice in 96, 97, and a thumb reimplantation. And if it's an avulsion injury, you have to do a secondary nerve grafting. That's a very important. This is the immediate, and then later on you can see that. And there are certain amputations where you cannot actually do a reimplant. This is the case. Many people they advise me that you just actually do an amputation and make a stump. But I was crazy in early days of my practice, and I used to spend many hours doing a reconstruction. And you can see here immediately after reimplantation, and then he had a subsequent some necrosis around the dorsal specs. I went ahead and covered it with a lateral arm flap. So many people they said that you do a groin flap because you have already it's a revascularized sign. But I did actually a free flap, and that's the result which required actually secondary reconstruction with a nerve grafting. So these are actually difficult and challenging cases when there is an avulsion injury. And avulsion injury, you have to put a nerve graft in a secondary state. Because in a reimplantation, your focus is mostly on the immediately restoration of circulation. Immediately, you once fix the bone, you try to restore a couple of tendons surrounding the nerve, surrounding the vessel, and then you put actually graft or repair the vessel, restore circulation, and then you do a tendon repair. And when the nerve repair turns comes, you are really tired and you just want to approximate the nerve end. So these nerves in a reimplantation, they are mostly neglected, and you are tired at that time until unless you have another team who can actually take over and do that. I will stop it here, and maybe if there are any questions we can entertain either now or at the end. Dr. Harun?
Thank you, Dr. Pervez Hashmi, for an elaborative talk on the pathoanatomy of the nerve injuries. Now you can unshare your screen. Now we will move forward towards the nerve injuries which are associated with fractures and gunshot. I will welcome Dr. Kamran Ahmed to please proceed.
Assalamu alaikum. Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Thank you, Dr. Harun, Pakistan Orthopedic Association, Dr. Pervez Hashmi, Brigadier Khalid Masood sir, and all the participants for joining in and letting me talk on this subject. And now, this is something we seldom talk about, although it is the most common part of nerve injury in fracture settings. So the learning objectives of this talk are that by the end of this session, we should be able to identify various common nerve and vascular injuries associated with fractures, list methods to avoid injuries during fixation, plan treatment based on current guidelines, and rationalize treatment for gunshot injuries. Now let's start with some specific fractures. Obviously, it's a very big dimension, so we cannot cover each and every bit. So I'm going to talk mostly on more common injuries or injuries that are very common and that are overlooked. So let's say clavicle fractures. Now, if you see this diagram, here you see that the clavicle, apparently seeming to be a very superficial bone, has very complex structures behind it, and above it and below it. In this diagram, if you see here, and I'm not sure if you can see my cursor, here is it. Now, you can see that the brachial plexus is right behind the scalenus anterior. It's between the scalenus anterior and medius. If you see this subclavian artery, the red one, and this is the subclavian vein. Subclavian vein is actually right posterior to the mid aspect of the clavicle. So it is quite common. Can be quite commonly injured because it is right next to the periosteum, and it is not covered by the scalenus anterior, it's anterior. Whereas the brachial plexus and the subclavian artery are relatively protected at this point by the muscle. As we go, so in this area, this is the area where we most commonly do fixations. And this is the area where we have to be very careful because there are very serious structures very close by. So there can be nerve injury, there can be arterial injury, there can be venous injury. Another diagram showing the same. And see here again, this is the scalenus anterior. You can see the subclavian artery on the back of it, the subclavian vein in front of it. And obviously the clavicle is right over the top here, and it is very close by these structures. And these are big vessels and very important part of the brachial plexus, the nerves, which can injure and lead to serious morbidity and at times mortality due to severe bleeding. Now let's see this diagram. If you see in this diagram, there is a plate fixing the clavicle, and just see the length of the screws as pointed out by this arrow. Now this screw, which is this long, can very easily injure So this injury, the injury to the subclavian artery, can occur if you have a screw like this. So be very careful while doing surgery for clavicle fractures. And if you are doing that, the size of the screw, the position of the screw, the method of fixation, the way you do your drills is very important. So this has to be taken into consideration. This has to be taken into consideration. Now, so again, now what injuries can happen here? There can be injury to the subclavian vein, and injury to the subclavian vein will present acutely. And you can have a patient who has who accentuates because there is a lot of blood going through the vein. You may actually have air embolism, and this is a real serious phenomenon. If you have such a phenomena, then you will have to put compress with a wet gauze. You have to stop bleeding. You may need you seek help of a vascular surgeon because this requires repair. And to prevent air embolism, one can actually keep the head down, lower down the head side of the table, and obviously, if you have a central venous line, you can even suck air from the right atrium. But again, you have to be very conscious of this injury. You have again, otherwise you will not be able to recognize why the patient has problems with circulation, why the patient have problems with respiration during your apparently simple clavicle fixation. As far as the arterial injuries are concerned, usually the arterial injuries do not present acutely. It is very uncommon to have an arterial injury during fracture fixation because the artery is a bit protected as compared to the vein, as we just saw in that diagram. But they may present late. So if you have any patient who presents any time between 4 months and 10 years with subcritical ischemia of the upper limb, subcritical ischemia, and there is a history of clavicle fracture fixation, so you should consider differentials like there can be some injury to the vessel. You might have ended with some sort of AV fistula formation or a formation of an aneurysm. If there is a AV fistula formation, one may actually end up with high output failure. So these are usually slow presenting injuries. So there can be ischemia, there can be high output failure, there can be swelling in the clavicular region, which may indicate that there is an injury which is causing subcritical ischemia or other vascular complications. So beware of these complications. As we go on to nerve injuries, you see here, there are many articles which have shown that there can be nerve injuries when you do acute midclavicular fractures, and they may present early. The patients may present with post-operative weakness and sensory disturbances. So at times, observation only may help if there is nothing else that you can find, and there is usually full recovery. But there is, especially in cases where you are operating later, like midclavicular non-union, there may be malunited fragments compressing on the plexus after plating and bone grafting. There can be post-operative neck and arm pain with weakness, and you may have to excise the bone spike in order to release this problem. And there can be immediate pain relief and partial motor recovery, as seen in this article by Namduri at 4 months. Then there can be midclavicular hypertrophic non-union. This may cause incomplete global injury. And the hypertrophic callus may compress on the plexus as it passes close to the bone and the bone grafted site. You may have post-operative pain and paralysis. It requires neurolysis, but if at the time of surgery you think that the hypertrophic callus is too much, you may actually have to excise the callus along with neurolysis to ensure a good post-operative recovery. J. Celan in 2013 has pointed on to a very significant part of approach to late appearing clavicular fractures, anytime between 4 days and 31 days from injury, or when you are approaching them late. So what he suggests that there is a traction injury to the plexus. Traction injury can even occur in some acute fractures, like when you are trying to do intramedullary nailing. So when you try to ream, you put pressure on the underlying vein and the underlying artery and the plexus. So what he recommends is that to avoid this nerve injury due to traction or due to displaced bone fragments, you have to release the adherent soft tissue. So release the periosteum underlying the midclavicle. Do not put any screws through the periosteum. It is very important. And this is a very good study given by him, and this may actually prevent a lot of injuries as a result of surgery. You may also have thoracic outlet syndrome, although the incidence is quite less, and there are again Many papers showing the same. There can be thoracic outlet syndrome in mid-clavicular delayed union with multiple failed fixation procedures. Now, what has been seen that revision fixation with curved plate and intercalary graft. So you have to restore the length. You have to restore the length of the clavicle in order to decrease the symptoms of the thoracic outlet syndrome. You mobilize the callus, release the compressed vessel. Similarly, in other articles, again in mid-clavicular non-union, a few cases of thoracic outlet syndrome have been seen. And revision fixation with a curved plate and intercalary graft, again restoring the length and decreasing the amount of compression at the costoclavicular space has shown good results. Similarly, there is another article in 2005 showing the same. In this, now you may actually have to do scalenectomy, first rib resection, and staged subclavian vein angioplasty at times, depending on what you have. If you have subclavian vein occlusion, you may even have to resort to angioplasty in specific cases. Now, this calls for help from a vascular surgeon. So be prepared. If you are going in with a surgery of thoracic outlet syndrome as a result of clavicle fractures, or if you are going in with a late clavicular fracture, seeking help from a vascular surgeon and beware of such a complication may actually prevent you from future complications. Now, what are the risk factors for neurovascular injury in clavicle fractures? A medial fracture in the medial two-thirds of the clavicle, comminution, 2 to 4 weeks delay in surgery, non-union, and malunion. So what are the recommendations for safety? What to do in cases of delayed presentation? There has to be a thorough evaluation. And a thorough evaluation and delayed presentation may actually mean a 3D CT angiogram, which may be very helpful, especially in cases of non-union or malunion. You have to communicate very well with the anesthetist, the communication regarding potential for vascular injury and air embolism. So if you have not done that, and if you don't alert them while you are drilling for screws and while you are doing the reaming, they may actually not know, and you may have a missed problem, and the patient may actually accentuate, or there may be an air embolism, and they may not be able to do the needful in the real time. Positioning, regardless of the patient position chosen, there has to be a facility for quick change of position in case of any emergency. You may have to do a lateral decubitus, you may have to lower down the head in cases of the vascular injury, or you may need to change the position to gain vascular access and actually change the surgery if there is a complication. Again, subperiosteal dissection in medial clavicular fractures is very important, especially when you are doing late injuries. Screws should not penetrate the periosteum. Regarding screw insertion, superior to inferior screws should be placed when you are doing the medial third. Ideally, when you're doing the middle third, anterior to posterior screws are far safer than superior to inferior screws. This is why antero-inferior plating has its role in medial third fractures, middle third fractures. The screw length should not be over 18 millimeters. Care must be taken while drilling the cortex, and blunt retractors need to be avoided. Now here, this is another cadaver dissection study published in Journal of Shoulder and Elbow Surgery. And what they have shown here, you see here, these are the values for safe clavicle surgery given in millimeters. The minimum distance measured from superior clavicle to the superior aspect of the axillary artery was 22.1 millimeters. The thickest clavicle measured over the axillary artery was 15.9 millimeters, and the thickest clavicle in the area of the clavicular plate was 17.6 millimeters. So the recommendation is to have a drill stop for mid-clavicular plate of 18 millimeters. Do not put any screws over 18 millimeters. And if you are putting the screws eccentrically, if they're not right in the middle of the bone, their size is going to be smaller. Beware of this fact, don't put larger screws. Another injury which is very commonly missed, and in fact not ever seen actually, is the injury to the supraclavicular nerve. Supraclavicular nerves are reality. As you see in this diagram, you may have actually 3 bundles of supraclavicular nerves passing right over the clavicle. So when you approach for clavicular fractures, if you are not knowing this fact, you may actually cut them very easily, considering them as soft tissue, and then there will be neuropraxia and at times very painful neuroma. So this is one of my case. You can see a superior plating and 3 bundles of supraclavicular nerves crossing the plate. This is number 1, number 2, and number 3. The lateral side is partly spared and have not gone all the way to the AC joint. So you can see this is a reality. Again, this was the area under the plate where 3 bundles were found, and they were actually dissected out and saved. So this is another article in 2013 which shows that there is a 97% incidence of a medial and lateral branch, and it's 49% incidence of a intermediate branch. And there is a safe zone of 2.7 cm from sternoclavicular joint and 1.9 cm from acromioclavicular joint. But what I would like to say is that you have to see these nerves because you may find variations. This is a general recommendation, so you should see these nerves when you are going for clavicular plating. And what is the problem? If you don't do that, there can be as high as 50% cases of numbness. Up to 44 square centimeters of area around the clavicle can be numb. And this is in cases where nerves are not found or cut. So this is actually underreported. So there is a very high underreported incidence of clavicular numbness. Let's go on to humerus fractures. Now, again, when we talk about nerve injuries, it is imperative to understand the anatomy of the nerves. So let's go on with the radial nerve and iatrogenic injury. Now, this is a very good diagram given in 2008, but let's see how confusing it is. This is a difference between Chinese and Caucasian populations. So if you see on the medial side, from the medial epicondyle to the radial nerve, there is a significant difference in millimeters between Chinese and Caucasian population. And even between the Chinese and the Caucasian, between the many subjects, there's a significant variation of the site where you can find it. Similarly, as you go on to the lateral side, you find the same. So this is quite confusing because if you have any value in millimeters where the radial nerve would be, you can be seriously wrong. So now what is good, this is another article in 2011. This is a very landmark achievement in an article. If you see this triceps aponeurosis, the apex here, 2.5 centimeters from the apex here, you will find the radial nerve in almost all cases. So you can very easily identify your radial nerve here, trace it there, trace it here, identify it, preserve it, and do whatever you want to do on the posterior aspect of the humerus. So this 2.5 centimeters proximal to the apex of the triceps aponeurosis is a very good landmark, and one should always try to seek that landmark while trying to find the radial nerve. So ulnar nerve, again, the anatomy and iatrogenic injury. Ulnar nerve runs very close to the medial triceps. In fact, if you see the medial triceps, it runs right alongside the medial triceps. It is a part of medial triceps in true sense. And then we need to know the anatomy of the ulnar nerve as it goes onto the cubital tunnel and as it goes into the medial intramuscular septum in order to avoid injury during various operative procedures. Let's take this fracture for example. If you are doing an intercondylar comminuted fracture of the distal humerus, we have to mobilize the nerve. This is a medial and lateral triceps windows, the paratriceps approach. So once you have fixed the medial plate on the medial side, you have to see that the nerve is not impinging on the implant so that there is no future injury. And then you can have the nerve through range of motion. If on range of motion there is no cross subluxation of the nerve, you do not need to actually do an anterior transposition. But if you find anything wrong, one should always consider an anterior transposition of the ulnar nerve in order to avoid ulnar nerve injury, especially in fractures of the supracondylar regions. Again, the mobilization of the nerve in these cases is very important. If you have not done adequate mobilization, you will not be able to mobilize the nerve for this subcutaneous anterior transposition. You have to release the septum, you have to mobilize the nerve to the first motor branch, and it is very important for this particular surgery. Going on to radial nerve injury with humerus fracture, the topic which has always been debated, and I don't know if we still have found the real answers. What are the reasons for nerve injuries? They can be open fractures, Holstein-Lewis spiral fractures, and penetrating trauma. Now, what is a Holstein-Lewis fracture? It's a spiral fracture of the distal third, the shaft of the humerus, with distal bone fragment displaced and the proximal end deviated towards the radial side with an increased risk of acute radial nerve palsy. Compared to other humerus fractures, there is a 22% risk of radial nerve palsy as compared to 8% in other fractures. It was described by Holstein and Lewis in 1962 and in fact published in 1963, where they put on 341 consecutive distal humeral fractures with 6 patients having radial nerve palsies, and out of which 5 had this specific fracture pattern. And what they concluded is that fracture occurred at the site of radial nerve as it runs through the lateral intramuscular septum in direct contact with the bone and with limited mobility, and that still holds true till today. So this is a diagrammatic representation of the same. At the lateral intermuscular septum, there is limited mobility, and the fracture fragment may actually cause injury. As you try to reduce, the nerve may actually entrap between the fracture fragments, and this is why, if there is a nerve injury post manipulative reduction, one may assume that the nerve is actually entrapped, and you should do a nerve exploration in most of the cases, especially if you are going for fixation of the fracture. So, what are the indications of primary nerve exploration? Open fractures with radial nerve palsy, distal third spiral fractures with loss of nerve function after close reduction. This is what is the journal teaching. But what I would like to add here is when we are doing fixation of humerus fractures and if the patient has a radial nerve palsy, one should have an approach to definitely see the radial nerve. There is no point in doing a ORIF of the humerus with the patient having radial nerve palsy and not seeing the nerve. One should always see the nerve if you are doing fracture fixation in such an instance. So when to do EMG, NCV, and how to proceed? EMG should be done at 6 weeks if you are doing conservative management. If motor action potentials are positive, one should observe. If there is denervation fibrillation potentials at 6 weeks, there is an option to explore and repair. And I would suggest it is ideal to explore and repair if you find these at EMG. And obviously, if it fails to recover, and if you have not done the exploration and repair, one need to resort to tendon transfers. Let's talk a bit about axillary nerve iatrogenic injuries. Now, this is a very good diagram to show where the axillary nerve is and how to avoid injury when you are doing percutaneous K-wire fixation. Now, X is the distance from the top of the humeral head to the lower part of the humeral head. And 2X is the starting point of the K-wires. So you have to start K-wires at this point. You don't start them here because this is the site where the axillary nerve winds around the humerus. And they should end in the humeral head. Similarly, when you are starting a wire here, it should end 2 centimeters distal to the lower part of the humeral head. These 2 centimeters, this is the 5 centimeters from the top of the acromion, from the point of the acromion, and this is the 2 centimeters. See in this diagram, this is those 5 centimeters, and these are the 2 centimeters that has to be avoided. So if we are going in for a deltoid split approach, what to do? We know if you are not doing a deltopectoral approach and doing a deltoid split in some injuries, we can injure the radial nerve, the axillary nerve. So what we need to do, we can actually put a suture here at the 5 centimeters so that this line does not extend any further. Another thing is you can put your finger inside the bursa and you can feel the nerve. And when you are doing things like MIPO, you have to slide the plate under the nerve. Be very careful, feel the nerve. If you cannot feel the nerve, at times you can even extend your split. But be very careful when you're extending the split. You are extending a split to see the nerve. So see the nerve and isolate the nerve. But it is preferable to not to extend the split, mobilize the nerve, use your finger to feel the nerve, slide a plate under the nerve, and use a distal stab incision like this one to do your further fixation. So be very careful with axillary nerve injury in proximal humerus fractures when you are doing plating using a deltoid split approach. Now, a bit about the supracondylar fractures in children. The incidence of nerve injury is 7 to 15%. Anterior trochleus nerve is most commonly injured, and you will find loss of OK sign. It's quite commonly that we see it is usually self-limiting, but we need to be aware of this problem because you need to document that. You need to tell your patient that this has occurred as a result of injury, not as a result of surgery. And again, if you have posteromedial displacement in order of severity and in order of occurrence of injury, radial nerve is more common than median than ulnar. If you have a posterolateral displacement, median nerve is more common than radial than ulnar. And flexion injuries are less common, but if you have flexion angulation, ulnar nerve neuropraxia, and it's usually neuropraxia is more common than any other injury. A bit about median nerve injury in distal radius fractures and lunate dislocations. Mostly it's a neuropraxia in distal radial fractures. It should resolve in 48 hours of manipulation. If there is excessive polar flexion in a cast, it should be reversed. Initially, it should be avoided, but if you find that, it should be reversed. If there is no resolution in 48 hours, exploration is indicated. In malunited fractures with median nerve compression, deformity correction is the aim, and carpal tunnel release is indicated as a part of the procedure. In perilunate dislocations, reduction of dislocation in carpal tunnel release is indicated as a part of the approach and surgery. Now, a bit about the gunshot injuries. Now, gunshot wounds are a spectrum of injury where the guidelines are actually very difficult to make because not every gunshot is similar. A close distance military gunshot will be different from many other gunshots from distance and with low velocity gunshots. So let's take this patient for example. This is a 20 years gentleman, and he has a gunshot. The bullet entered from here, in fact, from here, and it exited from here. Now, sorry, it entered from here and exited from here. So what to do? Now, this patient has presented with this injury. So we can see that there is ulnar claw. The patient was unable to do abduction and adduction of the digits. So this is a most likely ulnar nerve injury. Now, do we really know? Is it neuropraxia? Is it contusion? Is it laceration? So should we go in and do the surgery? So this is what we found in surgery. If you see that the bullet went right into the nerve, and it has split the nerve, and part of the nerve is severely crushed and damaged. So if we leave this injury, without a surgical exploration, there is a very significant chance that this is not going to recover well, and there will be significant morbidity as a result of injury. So this article demonstrated that in 59 exposed nerves in 41 patients, 59% were intact, 24 were contused, and 17% was lacerated. Now, 17% incidence of laceration in patients presenting with neurogenic symptoms is a big number. So the operative exploration should be strongly considered due to high likelihood of nerve laceration. Although this continues to remain a debated topic without clear consensus. So the incidence of traumatic nerve laceration after a gunshot wound to the upper extremity is likely higher than previously believed, and the delayed exploration of patients with partial or complete nerve laceration may result in inferior clinical outcomes and increased morbidity. Now, why early exploration and repair? You will need shorter graft lengths. You will avoid dissection through a very dense scar. Nerve can be identified and tagged to a nearby structure to prevent retraction if you cannot repair it at that time for any reason. In contusions, epineural release can be performed, and this will actually decrease the chance of intraneural edema. And this will definitely make your outcomes better in patients with contusions. And the repair is obviously easy when you go in the index setting. So the proponents of delayed repair say that there is a clear demarcation of the zone of injury, and you avoid two surgeries. But there is more and more a shift towards early nerve exploration in cases of nerve injuries, especially in the upper limb. And I would recommend that it is a very careful decision, and any doubt about the severity of injury, one should try to explore. So what's the take-home message? Common nerve injuries should always be identified in upper limb fractures. Avoid nerve injuries during fracture treatment. And the only way to do that is you should have excellent understanding of anatomy, which is the key to success in all surgeries. Proactive treatment of gunshot injuries is needed for excellent outcomes. Thank you so much.
Thank you, Kamran, for an excellent talk. Now I will request Dr. Khalid Masood to share various options of a nerve transfer in nerve injuries. Dr. Khalid.
Assalamu alaikum. We had a great talk by Professor Pervez Hashmi regarding concept of nerve injuries, their anatomy and pathophysiology. And I really feel that and no one can think of repair or doing something regarding nerve injuries until and unless he is completely aware of its pathophysiology. As Professor Hashmi already has given a great knowledge regarding regeneration process, so one must keep in his mind that the regeneration process is very complex process regarding nerve repair. So while doing the nerve repair, it is not only enough just to approximate the nerves until and unless one is quite aware of the pathophysiology. So why we go for nerve transfer? Because the primary repair of high peripheral nerve injury mostly results in uniformly poor outcome as a result of great distance between the site of injury and the innervated muscle. Till 1995, 1997, the decision regarding the nerve transfer was very controversial. Very few people tried it, but the results were very equivocal in all those conditions. But from 2007 onward, a lot of people work for nerve transfer. They were thinking that what should be doing, what should be done for high nerve injury, where the outcome is very poor. So they brought many solutions which come on literature uh, after 2009 and 2010. In our practice in Hulls, we started this nerve transfer since 2015. And Alhamdulillah, we are performing routine nerve transfers for high peripheral nerve injury with very comprehensive and very satisfactory results. As far as high ulnar and median nerve injuries are concerned, a complete ulnar nerve injury results in denervation of the intrinsic musculature of the hand and severe functional deficit, including weak grip and key pinch, and motor deficits warranting reconstruction relate to thumb and index eye flexion and pinch and grasp strength. And there is also loss of thumb opposition with median nerve injury. And there are certain factors which address the nerve transfer and associated with poor outcome. Basically, these factors are the indication for which we think to do the nerve transfer. Or in our setups, for all these factors, we go for nerve transfer as far as peripheral nerve injuries are concerned. What are these factors? The nerve which have proximal nerve injuries. And what is meant by proximal nerve injuries? All nerve injuries above the elbow level. जो जहाँ पे जिस तरह की भी ये इंजरी होगी, हम ultimately we think, मतलब after repairing the primary repair, we think for nerve transfer in these cases. And all those cases which show delayed repair, and when there is a tension at nerve repair site, and when there is inappropriate sensory motor internal topography alignment, and all those injuries which require graft. These all cases should be thought for nerve transfer, because all these factors lead to poor outcome as far as nerve repair is concerned. And there are certain factors which influence outcome of nerve transfer. One have to keep their mind when they think for nerve transfer, all these factors. These factors include synergy between donor and recipient. This is the same as we think for tendon transfer. The next important factor is the fiber count match between donor and recipient. And then the most important is recipient functional demand. Like small muscles of the hand, they have complex functional demand. So for such cases, the outcome may be unpredictable as far as nerve transfer is concerned. Then the surgical technical difficulty. Then the quality of rehabilitation protocols, motor re-education. This is the most important factor as far as nerve transfer is concerned, because it is never possible that you perform the nerve transfer and send the patient home and ask him to come after 6 or 8 weeks to show that what is the outcome. So you have to bind yourself with the patient, and that actually starts immediately after surgery, and you can say that very next day after surgery. Then there are certain transfer options. since we are doing this, so what we do, we manage high ulnar and median nerve injuries by distal nerve transfer. What are these transfers? High ulnar nerve injuries in adults where functional restoration was achieved by using the distal branch of the anterior introitious nerve, which was transferred to the distal motor branch of the ulnar nerve. And then for median and mixed high, median and ulnar nerve injuries, we manage with the transfer of the supinator branch to the FTS and branch to ECRV to AIN. And then for sensory regain, dorsal radial sensory nerve was transferred to the index finger, palmar nerves to restore the sensory loss. And then the third space median to ulnar transfer was performed to restore the ulnar sensory loss. And post-op management is very important. As I already mentioned, motor rehabilitation was initiated immediately. And motor rehabilitation included passively movements of the fingers and wrist, active finger movements, electrical stimulation of the denervated musculature, and pinching exercises during resisted forearm pronation. And what about high ulnar nerve injury? This is basically the diagrammatic planning. There is anterior introitious nerve, which is a branch of the median nerve. When it passes through the pronator quadratus, so it is taken and transferred to the motor branch of the ulnar nerve. Like in this way, it is transferred to the motor branch of the ulnar nerve. Like in this case, this is a 30-year male, and he had an injury by the sharp object 5 months before. This is the area of the injury. So the nerve was explored, and it was repaired with sural nerve graft cabling, as already mentioned by the Professor Hashmi. And patient was having impending climb. So in such case, one must keep in mind that the nerve repair and outcome will be very poor. So one must consider the nerve transfer in such cases. So this is the exploration of the area and pronator quadratus, and the motor branch of the ulnar nerve was isolated. And here the anterior introitious nerve, which was going through the pronator quadratus, it was harvested, and end-to-end anastomosis was performed. And this is the situation after 9 months, abduction and adduction. And what about high median nerve injury? The scheme for high median nerve injury is to take the utility of the pain nerve. One can take the branch from a pain nerve, and that is basically the ERCB branch, and it is transferred to the anterior introitious nerve. So most of the functional areas are covered by this transfer. And this is an example of the case, like the previous one, the median nerve injury, which was repaired by the cable sural graft, and the defect was covered. But then the nerve transfer was also performed. But still there is an issue in such cases. That issue is opposition. Because of having the small muscle, the problem with opposition is still in such cases. So what we do, we will do EIP transfer for opposition in such cases. And for sensory loss, again, we take the cutaneous branch of the radial nerve which is transferred to the digital nerve of the index finger. So it covers most of the functional loss by the median nerve. So 2-point discrimination and index finger returned completely in 42 weeks, particularly in this case. And overall outcome is very good with this transfer. And what to do when there is a mixed nerve injury? As median and ulnar nerve are passing through the same zone in the arm, and many a times with bullet injuries or any accidental injuries, many patients, they present with both median and ulnar nerve injuries. So when there is such situation, then what should be the plan? Like in this case, it was a 27-year military officer. There was history of firearm injury right at upper arm, and initially managed in other hospital where the brachial artery was repaired and nerves were tagged. And there was high injury to both the ulnar and median nerve. So it was referred in our center because there was no flexion at the wrist and fingers. It was all possible flexion of the wrist and all possible function of the fingers. So distal nerve transfer was planned. And what is the available option here? The available option is only the radial. And the plan was supinator branch, transfer of supinator branch to the FDS and ECRB branch to anterior introitious nerve. This is the incision mark. And the median and pin branches are identified here. This is the median nerve, and this is the pin, posterior introitious nerve. Then the anterior introitious nerve and nerve to FDS, supinator, and ECRB branches are isolated. All these here, these are the recipients, and these are the donors. All are isolated. And transfer of ECRB branch to the AI nerve to the anterior introitious was performed here. And the transfer of supinator branch to the FDS with a small nerve graft was performed here. Then again, the cutaneous branch of the radial nerve transferred to the radial digital nerve for sensory loss. So after 24 weeks, it was the recovery and very comprehensive and very reasonable recovery after 24 hours. So another case, the 34-year male, gunshot injury right upper arm and 6 months history. And there was another, in the same case, there was another injury in the lower arm. And it was a bullet injury, and bullet entry point was posteromedial and exit was anterolateral. This was the exit and this was the entry point. It was again managed in other hospital where the brachial artery, ulnar nerve and median nerve were repaired at elbow level. It then referred after 6 months of the management with clinical findings. What were those findings? That patient was unable to flex the elbow, wrist and fingers. And nerve conduction studies showed loss of musculocutaneous nerve with negligible recovery in median and loss of median and ulnar nerve. And that was the NCS EMG study. And patient had got injury to the median, ulnar and musculocutaneous nerve. So on examination, there was inability to flex and the fingers and wrist, and there was inability to flex the elbow. So again, the transfer of the supinator branch to the anterior interosseous nerve and ECRB branch to FDS was performed uh, for median and ulnar loss, and Oberlin transfer was performed for musculocutaneous nerve, where the motor fibers of the ulnar nerve to MCN were transferred. So on recovery, when the patient presented, this was the only finding. And after 24 hours, you can see the flexion of the fingers and position of the finger as well. And after 36 weeks, it was very good, excellent for flexion and finger movements. Although it were weeks, but the movements were excellent. As far as high radial nerve injury is concerned, there are many options are available. As far as the transfer is concerned, still there is a controversy whether we should go for radial nerve transfer or not. But people have started nerve transfer for the radial nerve injury nowadays. We have been doing it, but we are doing in a certain conditions. We are doing it for in children, but we are doing the internal splinting right at the time with the tendon transfer. We are transferring pronator teres for the wrist extension, and then the nerve transfer for the finger flexion, for the finger extension. But there are many options available. These are FDS to ECRB and FCR to pin, and FDS to pin and FCR to ECRB. And one can do the FDS to pin and palmaris longus to ECRB as well. The other option is nerve transfer of pronator to nerve of pronator teres to ECRL and nerve of FCR to pin, and nerve of FDS to ECRB and nerve of palmaris longus to pin. And other options in radial nerve injuries, these include the pronator quadratus to ECRB and supinator to pin and brachialis to ECRL. We have used brachialis in couple of cases with very good results. But as I told you that we go for internal splinting by tendon transfer and do any one of the nerve transfer, particularly FDS to pin, that in our experience they have much better results. So this resulted, a nerve transfer resulted in timely return of the function to the ulnar and median innervated extrinsic and intrinsic muscle of the hand that were documented further by the electromyography. Sensations were also improved, measured by the fine touch, pain, and 2-point discrimination test. For high, median, and ulnar nerve injuries, this type of nerve transfer is a much better approach than the traditional primary neurorrhaphy, as this converts high ulnar repair to the distal ulnar repair. So in summary, peripheral nerve injuries are challenging problems. Nerve transfers are having many options available to the surgeon caring for these patients. Distal nerve transfers for treatment of high ulnar, median, and other peripheral nerve injury allow for a shorter re-innervation period and improve recovery, which is best to get the function of the hands. Thank you very much. If there is any question, welcome.
Dr. Khalid, thank you very much for an excellent and elaborate talk. It was really heartening to see actually this kind of work you're doing. You see, I intentionally did not put myself in that talk for the last 10 years. I have a couple of comments regarding Dr. Khalid's presentation. मैं ये कह रहा था कि ये जो सेंसरी न्यूरोटाइजेशन हम करते हैं, मैं से पहले ये शुरू किया था, लेकिन मैं अब सेंसरी न्यूरोटाइजेशन बिल्कुल छोड़ दिया. I do not do sensory neurotization for a loss of radial nerve at all. बट मीडियन अल्नर नर्व के लिए जब भी मैंने रेडियल नर्व की ब्रांचेस लेके सेंसरी न्यूरोटाइजेशन की है, मरीजों को कॉर्टिकल रिप्रेजेंटेशन का इशू होता है. उनको जो परसीव होता है कि वो डॉर्सम ऑफ हैंड पे टच कर रहे हैं. अब डॉर्सम ऑफ हैंड की रेडियल नर्व की कोई भी ब्रांच ले तो ये एक इशू है. तो फिर जब भी मुझे मीडियन अल्नर नर्व हाई नर्व इंजरी होती है तो मैं नर्व रिपेयर जरूर करता हूँ वेयर एवर इज पॉसिबल, और नर्व ग्राफ्टिंग जरूर करता हूँ मैं मीडियन नर्व की. बट एट द सेम टाइम आई डू अ नर्व ट्रांसफर फॉर मोटर रिकवरी. तो मोटर रिकवरी के लिए मैं नर्व ट्रांसफर करता हूँ. एंड सेकंड, मैं सर्टन पीरियड के लिए इमोबिलाइज भी करता हूँ. इमोबिलाइजेशन का मतलब ये है कि मैं कोई 4 हफ्ते के लिए उन्हें स्प्रिंट देता हूँ, क्योंकि इसकी रिपेयर का सारा दारो मदार इस बात पे है कि आपकी रिपेयर टेंशन फ्री हो. रिपेयर जो है आपको पता ना टेनो सुचर से होती है, क्योंकि जब भी आप ये खास तौर पे ये करते हैं, नर्व रिपेयर करते हैं और छोटी छोटी नर्व्स होती हैं, उसमें ये इशू होता है. तो बाकी काम तो माशाल्लाह आपका बहुत अच्छा है. और वो चीज़ लोगों तक मैसेज पहुंचाना था कि नर्व ट्रांसफर्स हाई नर्व इंजरी में एक ऑप्शन है, और जहाँ पे लोग खुद नहीं कर पाते, सिर्फ नर्व रिपेयर या ग्राफ्टिंग पे इक्तफा ना करें. अल्नर और मीडियन नर्व इंजरी में मोटर फंक्शन का आना बड़ा जरूरी है, और मोटर फंक्शन आते आते 2-3 साल लग जाते हैं. और जब मोटर फंक्शन आता है तो इंट्रिंसिक फंक्शन नहीं आता, थिनर हाइपोथिनर का फंक्शन और लंब्राइकल इंट्रोशियाई का नहीं होता. तो ये एक अब स्टैंडर्ड है कि अगर आप ऊपर नर्व रिपेयर भी करें, नर्व ट्रांसफर भी करें, तो नीचे आपको डेफिनेटली हर हाल में आपको नीचे जो है ना मोटर नर्व ट्रांसफर करना ही करना है. तो ये एक स्टैंडर्ड बन चुका है और लोगों को मेरा ख्याल है ये फॉलो करना चाहिए.
आई टोटली एग्री. आप मुझे सुन सकते हैं डॉक्टर प्रोफेसर हाशमी सर?
जी जी मैं सुन रहा हूँ.
हाँ, बिल्कुल आपने बिल्कुल दुरुस्त कहा. आई टोटली एग्री. इवन आई से दैट इफ इवन यू प्लान फॉर नर्व ट्रांसफर, प्राइमरी रिपेयर मस्ट बी डन. प्राइमरी रिपेयर को नहीं छोड़ना, वो आपने इन एनी केस करनी है. इवन इसमें अगर आपको ग्राफ्टिंग भी करनी पड़ती है तो वो फिर भी आपने करनी है, क्योंकि विद द पैसेज ऑफ टाइम जो सेंसरी रिकवरी है दैट बेसिकली डिपेंड्स अपॉन योर प्राइमरी रिपेयर. इट मस्ट बी डन इवन यू डू द नर्व ट्रांसफर इन डिस्टल एरिया. और सेकेंडली जो रेडियल नर्व की सेंसरी ट्रांसफर हैं, वो भी आपका पॉइंट बिल्कुल दुरुस्त है. उसके लिए व्हाट वी डोंट डू फॉर एंड टू एंड एनास्मोसिस, वी डू फॉर वी गो फॉर एंड टू साइड एनास्मोसिस. हम जो उसकी डोर्सल ब्रांच लेते हैं इसकी रेडियल नर्व की, दैट गोज एंड टू साइड टू द डिजिटल नर्व ब्रांच. तो इन सच केसेस हमें कोई इतना इशू नहीं हुआ कि जी हमें कोई इस तरह की कार्टिकल डिसेंसिटाइजेशन या इनसेंसिटिविटी का प्रॉब्लम हो. और थर्डली बिल्कुल आई एग्री विद यू कि जी फॉर ए पीरियड ऑफ टाइम उसको रखना चाहिए इमोबिलाइजेशन. बट फॉर फिंगर मूवमेंट्स उतना पोर्शन आपको जो है ना वो अनकवर रखना चाहिए. एंड वी स्टार्ट मूवमेंट्स passive and assisted sort of movements immediately after surgery. And as far as repair is concerned, we are using fibrin glue in addition to the micro suturing. So with the addition of fibrin glue with micro suturing, generally the repair is very stable and less likely chance of disruption in such cases. थैंक यू सर.
बिल्कुल सही कहा सर, थैंक यू वेरी मच. अगर किसी और का क्वेश्चन है मेरी टॉक से रिलेटेड, कामरान की टॉक से रिलेटेड, आस्क, बिकॉज इन चैट नोबडी हैज सो फार गिवन एनी क्वेश्चंस. किसी ने क्वेश्चन पूछे नहीं है. बाकी ये हमारा अपना तो नॉलेज शेयरिंग करने पे, और ऑब्जेक्टिव ये था कि ट्रीटमेंट मोडेलिटीज़ का लोगों को पता हो, क्योंकि ये नर्व ट्रांसफर्स बड़ा रिसेंटली इमर्जिंग फील्ड है और पीपल फेमिलियर होंगे तो तभी ये केसेस रेफर करेंगे। एंड अल्टीमेटली बेनिफिशरी जो पेशेंट होता है, हमारा एम तो ये होता है पेशेंट को अर्ली फंक्शन रिस्टोर करें और वो हैंडीकैप ना हो। दिस इज अल्टीमेटली ऑब्जेक्टिव, और वही होता है कि नर्व ट्रांसफर मोटर ट्रांसफर जब आप अर्ली करते हैं तो रिकवरी अर्ली आती है। फिर लेट आएंगे, साल बाद भेजेंगे तो फिर हमारे पास कोई फायदा नहीं उन पेशेंट्स को, क्योंकि न्यूरोमस्कुलर जंक्शन डेड हो चुके। ओके, थैंक
Okay.
विद दिस वी कंक्लूड दिस आवर सेशन। ओके सर, थैंक्स।
Thank you, sir. Thank you very much.
Thank you, Dr. Hashmi. Thank you, Dr. Khalid. Thank you, Dr. Kamran, for such a wonderful elaboration on the nerve injuries. It was an excellent talk. It highlighted everyone about these common problems and how do we handle them correctly. So this concludes our webinar today. We don't have any questions up till now. We are having this webinar today from 4 to 6. It is on current trends in the management of DTH.